Thank you so much for joining the consult group for neurodiversity affirming providers from Holistic Child and Family Practice. Today we have an amazing talk by a fabulous human who is both a social worker and a mental health nurse practitioner. I'm just going to turn it over. I'm so excited. Please welcome Morgan Burdick.
Hey folks. I Zach has already given me some I don't know how four-letter wordy I can get. Zach has given me some flack in the chat. I asked Zach to help me with the chat a little bit because I want folks to be able to participate all over the place. If you want to unmute yourself and ask a question, go for it. But Zach's also going to help call them out from the chat so I don't miss anything. I may ask folks to hold questions for a point that they'll come up later because I got a lot of stuff to talk about. But let's get started. All right. Okay. Interesting. It's telling me I can't screen share.
Why is it telling you that?
Great question, Zach. Can you fix it?
I mean, if you want to send me it, I can try sharing
All
it from my computer.
right, let's try it
Oh,
one more time.
It it looks like you're screen sharing now.
Okay, there we go. That looks promising. All right, cool. So this is my attempted brief overview of mental health medication information for non-prescribing mental health providers. This one's just going to be kind of general. In August, I'll be back and I'm going to talk about ADHD treatment specifically and highlight some of the different experiences of autistics within ADHD treatment. Um, so those things will all be covered, but they're not going to happen today. All right. So here's my hot take. I think that therapists have an important role to talk about mental health medications with their clients. I know that when I was in social work school, there were a lot of things that I didn't know about medications that looking back now, I can say, hey, if I had had more information, maybe I could have been more effective or more helpful for my clients. And I think it's fair to say this while staying within the scope of practice of someone not educated to manage medications, because often you all are the folks that your clients trust the most, that see them the most, that are less scary than potentially their medical providers. So there's my hot take. I think this is important and helpful, even for people who will never manage medications and never have an interest in doing so. All right. So I like talking about bias. So here is a list of mine. I'll let you read them, but in general, medications are not so amazing that they should be used as a standalone treatment for the vast majority of things. In a lot of situations, like mild symptoms, medication shouldn't be first line when therapy or other forms of treatment are accessible. The other thing I think I need to call out here is the field of psychiatry has done immense harm in criminalizing and stigmatizing people disabled by mental health conditions, as well as developmental and intellectual disabilities. And that can be true. And at the same time, these medications can be helpful and life-saving for people when used appropriately. Yeah. Another value that I hold is that people seeking mental health treatment deserve the most effective and best understood treatments at the most accessible costs. This means that we need to understand the best available evidence and research, and that evidence and research will change. So disclosures, this is pretty common. Doing disclosures is much more common among the medical side of folks. And part of that is because a lot of medical providers are taking money from pharmaceutical companies. So we'll talk a little bit more about that. But my disclosures are I don't have any conflicts of interest to disclose. I do have another job I won't be talking about here, but nothing I say here reflects that job. It does reflect the views of my practice because that's just me. Any binary or gendered language in this presentation reflects that in the research rather than excluding the experiences of queer and trans people. But it would be inappropriate to use language of people that have been excluded from the studies also. So where I present my clinical experience or opinion, I will do my best to tell you that. And I'm going to discuss off-label use of medication. So why do disclosures matter? There is huge, huge money in influencing the perspectives of medical providers. In 2021, medical providers in the United States received $1.87 billion from the pharmaceutical industry. And a lot of that is physicians, but I will call out that nurse practitioners and physician assistants are taking this money too. All that data is up there for you. The Sunshine Act is what requires medical providers disclose that they're taking this money, and you can look that up. The image at the bottom is actually hyperlinked to CMS's Open Payments website. You can go there and you can put in the name of any healthcare provider and you can see how much money they've taken and from whom. This is something that I recommend that my patients do. And when I'm seeking healthcare, you best believe I look up the healthcare provider to see who they've taken money from. Sometimes it's surprising. I've been in groups of other mental health providers and I've learned, oh, hey, so-and-so is actually taking $100,000 as a paid speaker from this company, and they didn't tell us that when they gave an opinion. So I think this is important. Lest the pharmaceutical industry be the only one I highlight today, I also want to highlight that the wellness industry actually has more money than the pharmaceutical industry that's wrapped up in selling their products significantly. So the global size of the wellness industry is $6.32 trillion. And I highlight this because many people who are suffering from medical conditions that they feel are being gaslit by their healthcare providers, from mental health conditions they feel like aren't getting better, are going to social media and they're learning these things and they're being exposed to a huge amount of direct-to-consumer marketing from supplement companies. And supplements are not regulated to safety and quality standards in the same way that pharmaceuticals are, which doesn't mean they can't be helpful, but we want to be thoughtful about where this information is coming from. All right. Zach, I can't see anything in the chat right now. You want to?
Yeah,
Turn on?
Corey was asking about the hyperlink for, I think it was the open payments
Yeah.
website. Are you gonna is that
I
gonna
am
be
happy
included
to
in the
share all these
PowerPoint?
slides.
Okay,
I
cool.
will,
Yeah.
yeah. And there's a couple of articles and stuff I hyperlinked in here too, so you'd have them for later because there's more stuff that I can talk about. So here, this is well, this one is from Choosing Wisely Canada, but these are some examples of things where medication is not first line and some things where they are. I tend to agree with this. I added opioid use disorder because medications for opioid use disorder are incredibly effective to this list, but the rest of this list is from Choosing Wisely Canada, which is, yeah. So I'll let folks read that. The reason for the difference with levels of depression between children and adults with antidepressants is that antidepressants have a lower effect size, meaning overall are a little bit less effective in treating depression in children. So they're reserved for more acute cases in children than they are for adults. I'll move on from there because you all have the slides. All right. So what is off-label use of medication? This gets thrown around a lot. People will say, oh, it's not studied, it's not safe, it's off-label. And some of that is true and some of that is not true. I think it's important for us to understand what off-label means because a lot of medications are used off-label in mental health care. So medications that are on label mean they've gone through 3 stages of FDA clinical trials for a specific diagnosis, a specific population, and a specific age range. Many medications are used off-label, especially in mental health, that we do know are safe because they have undergone an FDA clinical trial for a different population or a different condition. And many of them have what are called open label trials that demonstrate they're effective for this condition in this population, but they are not on label. So off-label medication use is more common in mental health practice. It's more common in pediatrics and in pregnant people because there are limited clinical trials of these populations. And it's more common with older medications because there's not money to do new clinical trials for them. So an example of this is I will use the medication clonidine, which is FDA approved to treat ADHD in children, but there have not been clinical trials done in adults. I will prescribe it to my adults with ADHD. and many of them find it to be effective. So that's an example there. There are clinical trials, there are studies in adults, but there are not clinical trials for this medication. So when you hear people say it's off-label, it doesn't mean that it's dangerous or ineffective. We want to understand carefully what that means. All right. Then I think a great question that people often ask me is like, when should someone see a mental health specialist or psychiatric specialist versus primary care? Great question. Because in the United States, primary care providers provide more than half of all mental health medications, whereas psychiatry or psychiatric specialists are prescribing about a third. So this table is purely my opinion. It's based on clinical experience, but this one's my opinion. So in general, I think that primary care, if the primary care provider is knowledgeable and comfortable to do so, can manage a lot of mental health conditions. Some examples that are appropriate for primary care to manage are straightforward antidepressant for depression, anxiety, PTSD, continuing current prescriptions when the dose is effective without problematic side effects and the medication's working and helpful. No previous medication trials, so a pretty straightforward condition where someone's tried no medications before. Financial barriers to accessing care with a specialist, or one mental health condition, one mental health medication. The situations where I'd recommend someone see a specialist are if they need a more thorough diagnostic assessment, because a psychiatric specialist has more time with each patient to focus on mental health. They've had previous medication trials, like 2 or more antidepressants that haven't worked for them. They benefit from longer appointment time. They have multiple complex mental health conditions, or they would like to reduce or simplify their medications. So we talk a lot in kind of colloquial world when we're talking about mental health medications about serotonin and dopamine, but there are actually so very many neurotransmitters involved in mental health. Serotonin and dopamine just get a lot of credit because we have medications specifically for those. So here's a fun graphic, and I want to complicate this story a little bit. So here, I'm not going to talk about these in great detail, but here are a list of a bunch of other neurotransmitters that we know to be involved in mental health. And this will change over time. We'll learn more, we'll learn different things about these roles of different neurotransmitters, and we might have more medications that target other neurotransmitters. So I did put on the side some medications that increase or decrease these neurotransmitters. I'm not going to talk a ton about this, but this is here for your reference. I will highlight a couple of things though that I find come up and I find to be useful when I'm educating my patients and clients. Cannabinoids, I talk a lot about. Cannabinoids are part of mental health, and there are some medications that target them. I'll talk a little bit more later about kind of the things to be aware of when we're talking about medications and mental health. Some people find them helpful. Many of the commercially available products can be less helpful for mental health. We'll talk about that a little more later. The other one I'll point out is adenosine. This governs the sleep-wake cycle. And when we put a lot of caffeine in our bodies, we block these receptors. And so our brain cannot get us to sleep mode. That can often be really helpful just to talk about. Other things, every drug has 3 names. This is super confusing to people. How many folks in here have been confused by drug names before? I'm raising my hand because I have been. Yeah. So I think it's helpful to understand where the different names come from. Love those hands, folks. Thank you. There's a trade name that's a proprietary name from the pharmaceutical company. That name is going to be what's on the marketing materials. If you're seeing commercials, they're for the trade name drug. The generic name is the name that goes with that medication across manufacturers. Then there's a chemical name. I'm not even going to try to say that because those are for the scientists. Those are for the drug developers. So here's an example. A medication called Wellbutrin, which might be the one you all know it as, that's the most common trade name. It's called bupropion generic, but it has all these other formulations and other names. That's all the same medication. This can be super confusing for everyone. So the way that I approach this is I teach my patients and clients the generic name of their medication. I educate about this. And this can be really helpful because sometimes people go and they try to get a medication and it has a different name and it's super confusing. So antidepressants as a group, they have a heck of a lot of uses. They can be used for depression, PTSD, anxiety disorders, OCD, bulimia nervosa, PMDD, hot flashes in menopause, fibromyalgia, and IBS. In general, they act on serotonin. They help, and I'll talk a little bit more about how that works, but some act on dopamine and norepinephrine as well. Typically, they take 4 to 6 weeks to become effective, but often people see side effects right away. Here's just a giant list of types of antidepressants. I'm not going to go more into specifics on them today, but I'm happy to field questions. So how do antidepressants work? I am curious, show of hands, who has been told that antidepressants increase the amount of serotonin in your brain because people with depression have less serotonin? I'm seeing some nods, I'm seeing some hands. Yeah, that's mostly a marketing strategy that came from antidepressant manufacturers in the 90s, and it's not highly accurate. And I think it's important to give accurate explanations and to explain to people that the science will change over time. That's part of science and healthcare doing its job. But there was an article that came out in 2023, this Moncrief et al. Meta-analysis, which is hyperlinked if you want to read it, that a takeaway people had from this is because the serotonin hypothesis of depression is wrong, these medications don't work. And there are a lot of methodologic flaws with how this analysis was done. But what they're saying is that the theory that people with depression have low dopamine, antidepressants increase dopamine, and that magically fixes depression, that theory is wrong. It's a lot more complicated than that. So I'm careful to educate folks that, and maybe some of you learned this in grad school too. I'm careful to educate my folks that we use these medications to inhibit the recycling of serotonin, which makes more serotonin available. And initially, they'll increase serotonin at the receptors. That's when we see side effects. So typically in the first couple of days. Then we need 4 to 6 weeks for the brain to adjust to that increased serotonin. And that allows an increase of a protein called BDNF, which allows our brains to make more neural pathways. And that takes about 4 to 6 weeks. So that's how I educate that. I have hyperlinked an article explaining the neuroplasticity framework and how to educate about it if people want that too. There's a couple of other mechanisms that we think are the ways antidepressants work. And this explanation also may shift over time as well. And we do know from large scale research that antidepressants are helpful to people as our information on exactly how they work evolves. So most common antidepressant side effects, I imagine these are not surprising to folks. Many people have seen these or experienced them themselves. So here's a bunch of side effects. Many side effects with antidepressants go away in the first week or two, so I put asterisks on some of those. Sexual side effects are really common, and this is something that research shows us as healthcare providers that we need to be asking people about because often folks won't volunteer this. Therapists may be more likely to get this information than like primary care or a psychiatric provider. So this is a place where a beautiful therapist intervention is helping to support someone ask about getting help if they're bothered by sexual side effects. And sexual side effects, unfortunately, typically don't go away as someone's body gets used to a medication, but there are ways to treat them. So another thing that I think comes up often is the difference between allergies, therapeutic effect, and adverse effect. So an allergy is like an anaphylactic reaction. It usually happens in minutes to hours. A side effect is sometimes part of the package of just what medications do. If we could get them only to do what we want and nothing extra, we would all be taking that medication. But unfortunately, medications do extra things too because we have these receptors in places that are not where we want them. Like we have serotonin receptors that are part of blood clotting. They're on our blood cells. So I gave little examples of kind of what these would look like and what you might hear from somebody. Any questions here? Has anybody seen this come up of like, what is a side effect versus an allergy? Cool. All right.
I didn't really think there was a distinction between the two, so I'm glad you
Yeah.
covered that.
And we might actually put side effects in the allergy list. I do that. That's reasonable. If there was a side effect that was so bothersome or dangerous, it needs to be flagged for other healthcare providers to not prescribe this medication. A mental health example of this is if someone has a response to an antidepressant that increased their suicidal ideation, I might indicate that as an allergy, so they're not prescribed that medication again, but I would be clear about why, because it's not a true anaphylactic allergy. All right, serotonin syndrome. We hear a lot about this. Serotonin syndrome can happen. It's actually hard to figure out how often mild serotonin syndrome happens because it's typically not reported. And usually the treatment for mild serotonin syndrome is to stop the serotonergic, the medications that increase serotonin, and wait and watch. So it's hard to give a real good estimate of how often it's happening. Anecdotally, this is a Morganism. What I have noticed is that my neurodivergent patients, clients are more likely to have really unusual medication side effects, and that some of these mild symptoms I have noticed happen more often in the neurodivergent adults that I see. I haven't seen any actual population data on this. So serotonin syndrome, I've got an image here of what early signs can look like. Agitation, restlessness, confusion, sweating, especially armpits, forehead, dilated pupils, shivering or tremors. These tremors can kind of look like this. They're usually fine tremors. Hyperreflexia, so jumpy reflexes, usually when tapped with a reflex hammer. Muscle twitching, GI symptoms, nausea, vomiting are most common. Diarrhea as well, elevated blood pressure. So there are prescribed agents that can increase risk of serotonin syndrome, like migraine medications, opioids, most mental health medications, and some antifungal medications. And then there are also non-prescribed medications, MDMA, cocaine, tryptophan supplements, St. John's wort, and dextromethorphan. Dextromethorphan is typically found in cough medicine. So this is a great place for therapists to be of help for folks. Whoops. Because sometimes folks just didn't absorb this information when they got it from their healthcare provider. And if you're noticing someone is having these symptoms, please send them to be evaluated the same day by a healthcare provider. Yeah, severe serotonin syndrome is life-threatening. That does require medical hospitalization. And it most commonly involves a class of medications called MAOIs. These are the ones at the very end of drug commercials when they say blah, 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 interact, don't take with MAOIs. That's these medications. We are not very commonly using these medications since there are access to other safer medications. They're pretty unusual anymore. Antidepressants and suicide risk. These are just kind of my hot topics. Antidepressants, all of them will have an FDA black box warning. That's the highest level of medication warning from the FDA for increased risk of suicidal thinking. This is a pretty controversial label, but it's one we have to talk about, and it's one that sometimes people have a lot of feelings about. And it's a great place for therapists, non-prescribing mental health providers to be of support. So suicidal thinking with antidepressant medications is most likely for people under 25 years of age, but it's not associated with increased risk of completed suicide. Untreated depression remains one of the largest mental health risk factors for completed suicide. So some therapist interventions here. I'm sure you all are doing all these things beautifully, asking about suicidal thoughts, especially for children and young adults after starting an antidepressant. Safety planning, especially around access to lethal means like firearms and medications. We'll talk more about medications. And then I always make the plug, carefully assessing for acute suicide risk versus chronic suicide risk before referring to emergency services. I see a question. Is there any reason why there's an increase in suicide risk when taking antidepressants? I've heard differing theories. Great question. So there's not a good reason why there's an increase of suicidal thinking. There is a theory that part of the reason that this happens is because when we start treating depression, people have an increase in activation energy, and increased activation energy can be associated with increased risk of suicide and completed suicide. So That's the same kind of phenomena that we see that when the daylight comes out in our region in springtime, there's an increased incidence of completed suicides because people feel just a little bit better. So I explain to my patients that sometimes this can be part of feeling better, is that you actually have enough energy to be starting to make plans, including thoughts of suicide. So that's the approach that I take to educating about this, but there's not a really great conclusive reason. Does that answer the question?
Definitely. Thank you so much.
Yeah. So safe medication storage. This is another fantastic thing for all of us to be working on together for folks. Medication should ideally be stored locked and out of reach of children, pets, teens, and adults at risk for suicidal behaviors. Because the risks with teens are especially high, I just educate folks if there are teens in your house, please store the medication safely. Refills can be limited for people at high risk for suicide, and then locking bags and dispenser, sorry for that typo, devices are available. I also talk with my folks about how to dispose of unused medications, because sometimes I have folks who just have like bags or bins of unused or expired medications. A great thing we can all do to reduce risk of lethality from suicide, which is our number 2 means for completed suicide. Number 1 is firearms, is to make sure unused expired medications are disposed of. So many pharmacies will take them back. Washington also has free drop boxes and mailers through MedTake Back Washington. You can call or go on their website. Again, you'll have the slides. And then another question that sometimes I get asked from folks, and I imagine therapists may too, is, hey, I took an extra dose of my medication, or I didn't take enough of my medication today. What do I do? And when it's an unintentional medication ingestion, the correct people to contact are poison control. They're available all the time. They have pharmacists and nurses. They give really great advice. So there's a number for Washington Poison Control. And then there's also a number for the ASPCA Poison Control for pets. Unfortunately, that one is a paid service. Also talk to the person who prescribed the medications, but right away, the first people to contact, because they'll pick up the phone, is poison control. All right, antidepressant withdrawal. There was a great New York Times article kind of critiquing psychiatric practice about not talking about this and gaslighting patients about this. Antidepressant withdrawal is a very real phenomena. Again, I'm curious, who has experienced antidepressant withdrawal? A loved one has experienced it. A client has experienced it. Yeah, it happens a lot. So this is a thing that often folks are not being talked to about when they're prescribed a medication. So this risk can increase with certain medications, especially paroxetine, that's also called Paxil, or venlafaxine, Effexor. I imagine if we had another show of hands, we'd see a lot of people who'd experienced it from venlafaxine or Effexor. It's most likely with medications that last shorter term in the bloodstream, meaning they have a short half-life. It's more likely in people who've been taking medication over a year. It's more likely in people who stop abruptly versus a gradual decrease, and it's more common with higher doses of medications. So this is a great spot for non-prescribing mental health providers to talk with people about. If you're hearing from somebody, I just want to stop my medication, this is a great spot to be offering information. Have you talked with your healthcare provider about that? Has anybody told you that it's more likely you could have medication discontinuation symptoms if you stop abruptly? There is a manualized therapy for medication deprescribing from the Treatments That Work series that I put in here if folks want to. It's mostly focused on benzodiazepines, but can apply to other things as well. So antidepressant discontinuation symptoms can look like flu-like symptoms, insomnia, nausea, imbalance, kind of like vertigo, sensory disturbances. The big one is brain zaps, anxiety, agitation. Generally, this is not medically dangerous, but it is very much not fun, and it can be really debilitating. The timeline for this is that symptoms typically improve in 1 to 2 weeks and typically resolve in 3 to 4 weeks. Of course, this is not true for everyone, and it's not terribly uncommon for people to have withdrawal symptoms that last for months. The frequency of that is very low. It's less than 1%, but there are so many people in the United States who receive antidepressants that it comes up pretty often. So, and then the critique that I have of my field is that mental health medications typically are studied for weeks and not for years or decades prior to FDA approval. So it's not until after these medicines hit the market and people are taking them for a long time that we learn if there's a risk of withdrawal. What are brain zaps or sensory disturbances? Does anybody who's experienced them want to speak to how that was for them? If not, I'll talk about it.
Yeah, like it literally, like I wouldn't say it literally felt like there was like electricity going through my head, but I was definitely like feeling sensations like similar to that, in my head and my arms.
Yeah. Jennifer, do you want to say something?
Um, Hi. Yeah.
Hi.
I sorry, I don't know what it looks like here behind me. I weaned myself off of Paxil against doctor's orders. Um, I don't recommend doing that. But I had the brain zaps and it felt like a jolt of electricity going up my spine. And it was almost jarring, like my arms would move and it would stop me in my tracks. And I'm in that small percentage where the symptoms went on for months. Um, as I was weaning myself off, it was pretty brutal.
Jennifer, I'm really sorry that happened to you. It
Yeah.
can be miserable.
Yeah, thank you. It was pretty miserable. But I got kind of pissed at my doctor. She told me I was going to be a lifetimer on Paxil. And so my autistic mind, and I didn't know I was autistic at the time, went into F you, watch this. I'm not going to be a lifetimer on this. And that was when I started my weaning process and I started searching for a new doctor that day too.
I hope you found a good one.
I'm still looking.
I'll also plug here, there is a new company, I don't know much about them, called Outro Health that specializes in deprescribing antidepressants. One of their leaders is Mark Horowitz, who's done a lot of this research. He also wrote a clinical guideline for deprescribing, the book's like this big, to be of help for healthcare providers. But I know plenty of folks who have kind of purchased that book and done it themselves. He has a lot of resources on his website too. Antidepressants in bipolar disorder. This is controversial. I mention this because I had a patient whose therapist, they kind of united and they were both really frustrated that I wasn't giving him, and this is, I got him and I explained this to him, but they were really frustrated with the medical system that he wasn't getting an antidepressant for his depression and bipolar. And the reason for that is that current best evidence, and you will meet psychiatric providers who are doing all kinds of things that are not this, has shown that antidepressants in bipolar disorder increase the frequency and severity of depressive episodes over time. So there is a reason that somebody with depression and bipolar may not be getting antidepressant medications. And everyone getting an antidepressant medication, because of this reason and because of another one that's at the bottom of the slide, should be assessed for, is their depression unipolar versus bipolar before starting an antidepressant medication. One of the reasons for that is that antidepressants can precipitate mania and hypomania in some people. What that looks like is someone who feels absolutely fantastic within the first 2 weeks of taking an antidepressant. That's like somebody who's like, I've never had this much energy before. I feel so great. This medication is the best thing that's ever happened to me. That is not a typical reaction. So this is a place where, again, you're probably seeing your clients more often than the person managing their medication. This is a really helpful place to say, hey, we need to talk with your prescribing provider. And you, that person who's seeing them and learning this information, can send them a fax, you can give them a call. This experience of antidepressant precipitated mania is often associated with bipolar disorder, but it is not necessarily diagnostic for bipolar disorder. So just because this happens doesn't mean someone definitely has bipolar disorder. Helpful to know, sometimes that gets confusing. All right, so antipsychotic medications is a whole class of medications. I'm not going to talk too much about them. What I will highlight here, they have a lot of uses. I'm sure those of you who work with children see all kinds of antipsychotics used for children. There are two that are FDA approved for behaviors in autistic children. I have thoughts about that. They typically act by blocking dopamine, and some have the added role of acting like an SSRI, like an antidepressant, increasing available serotonin. This is a big meta-analysis. This came from the American Academy of Pediatrics. Antidepressants should not be used for, antipsychotics, that should not say depressants, should not be used first line for disruptive behaviors unless in children, unless there is an urgent safety risk for that child. And the reason for that is that these medications also have a lot of side effects. They increase cholesterol, increase blood sugar, increase risk for diabetes, can be associated with weight gain, all of them kind of more or less on this. And they can also be associated with involuntary movements, like a shuffling gait. So you'll kind of see somebody who's hunched over and their feet are moving kind of like this, shuffling. And then mouth movements. This may be something many of you have seen. It can be like clicking movements or tongue darting in and out of somebody's mouth. That's most associated with older antipsychotic medications in doses that we don't really use anymore. Mood stabilizers. This group of medications is usually used to treat acute mania and reduce future mood episodes. So when they're used, they're typically used daily. There are several antipsychotic medications that are also effective mood stabilizers in bipolar. These ones, helpful therapist information to know, abruptly stopping these medications can increase risk of mania in some people with bipolar. So again, another one that it's really helpful to have somebody take down slowly if that's what someone's wanting. Many of these need close blood work monitoring and can have interactions with other medications, some of which include making oral contraceptive medications ineffective. So this is a great one. You might know someone about someone's reproductive goals. You may be learning this in session. You may hear, hey, I started a new medication. A great question to ask would be, does the person managing your mental health medication know about this new contraceptive? Did the person who prescribed the contraceptive know about this mental health medication? Sometimes there's not great communication there. I will talk specifically about lithium because lithium is great stuff. It should be on the top one here. I'm not sure what happened to it, but yes, that is a mood stabilizer medication. And there's a whole slide. So lithium, I am a dork. So fun fact about lithium is that the baths in Bath, UK were thought to have medicinal effects because of the high lithium in the bath, which can absorb through the skin. So this is one of our oldest mental health medications in the West. It's a gold standard medication for the treatment of bipolar disorder. It has been shown in people with bipolar disorder to increase lifespan and reduce frequency of mood episodes. Lithium levels need to remain in a specific range to be effective and to avoid harm to the kidneys. So people taking lithium need to be careful with things that will alter blood levels. NSAIDs like ibuprofen are an example of that. Alcohol, prolonged sweating, major changes in hydration, and then use of prescribed or non-prescribed diuretics. So if you were seeing someone who had been doing so well on lithium, they were going to take great care of their health, and they decided they wanted to run summer ultra marathons in Tucson, this would be a great thing to check in with them about. Like, hey, have you talked with your healthcare provider about any risks related to your lithium and hydration now that you're going to be running ultra marathons in Tucson? Or if they decide to take up sauning for their health, whatever it is, good things to have in the back of your mind. Another one, lamotrigine, is a very popular mood stabilizer as well. It's often used off-label for kind of mood regulation difficulties. And it interacts with estrogen. So it limits the options for oral contraceptives. There are some non-estrogen oral contraceptives that can be used. There is not research available for gender-affirming care with estrogen, but what there is research for, and this is the approach that I take, is there is research looking at lamotrigine levels in pregnancy. So what I like to do for folks is get a blood level of their lamotrigine before a dose change or before initiating gender-affirming estrogen, and then after, so we can see what's going on. So that can be a helpful thing just to know. This is an area where, unfortunately, our folks receiving gender-affirming care do deserve better research. It's not good. That's the approach that I take. I think this is important to think about because gender-affirming estrogen is dosed higher than it is for hormone replacement in menopause or for oral contraceptives. So there's potential for more interaction there. The other thing that I will plug here is lamotrigine has a side effect of a potentially life-threatening rash. It's called Stevens-Johnson syndrome, and that needs to be evaluated in the same day in the emergency department, urgent care, primary care. It needs to be seen in person. It's most likely in the first few weeks. And if this medication is stopped for more than 5 days, it can't be restarted at the same dose because of the risk of rash. I do have some photos of the rash. If you don't want to see it, this is a good time to look away from your screen, and I will let you know when it is safe to come back if you don't want to see rash photos. It's changing the slide in 2 seconds. Here we go. So I think it's important to look at something like this on melanated and non-melanated skin because it looks different. So what's unique about this type of rash is often it will be painful. It will more often occur in the mouth, tongue, nose, hands and feet. Those are all pretty atypical rashes, and it's often accompanied by a low-grade fever. Again, this is a medical emergency. This is an emergency department trip. All right. Folks who did not want to see a rash, it is now safe to come back. Sleep medications, they are not first line for chronic insomnia, but you will sure see people get them like their first line for chronic insomnia. And they have risks. Longer term risks of sleeping medications can include rebound insomnia, so difficulty getting to sleep, staying asleep, and they can change the brain's ability to sleep over time. They are also associated with an increased risk of dementia, but so is untreated insomnia. So this is a real risks benefits conversation for each individual person. I put in there some less risky medications. And in general, the sleep medications work very similarly to other sedating substances like alcohol and cannabis. They put you out like anesthesia, but they don't provide restorative, restful sleep that helps re-energize people. And when you stop any of them, same issues with increased difficulty getting restful sleep, getting to sleep, staying asleep. So what about melatonin? Lots of people take lots of melatonin. I do not recommend it. Neither does the American Academy of Sleep Medicine, because over-the-counter melatonin is not regulated. So doses can vary widely. It's not studied for long-term use, and it's not recommended for chronic insomnia. This is a hormone that your pineal gland, your brain, makes for you every day. And when we give people exogenous outside the body hormones, it can impact the way that our body can make its own hormones. There's not a lot of good research on long-term use of melatonin, so we don't know that that definitely happens, that people's their body's ability to make melatonin could decrease over time. If people are going to use melatonin, the best evidence is using doses that are way lower than most people are using. Doses 0.3 to 3 milligrams have the best evidence. And if people are going to use it, you want to take it in your brain's window where you would normally make melatonin, which is typically around dinner time. Melatonin is not absorbed well with food, so I typically recommend if folks are going to take it, they take it about an hour after dinner time. And its best use is for helping your body get on to a new circadian rhythm, a new sleep-wake rhythm. So appropriate for short-term use with like jet lag, for example, would be a reasonable use. It is effective to help children with ADHD and autism get to sleep, but again, not studied for long-term safety. And the American Academy of Sleep Medicine recommends against parents giving their children melatonin without consulting with a healthcare professional. If people are going to use it, it's important to get third-party tested melatonin so you have some idea of what dose is in it. USP is a company that does third-party testing, and their 2 brands are always USP tested. That's a Costco brand, Kirkland Signature, and Nature's Way brand, if people need some guidance there. And then if people use Consumer Reports, you can also look up supplements there. They will show you the testing information. So another hot topic that I bet many of you have seen or been asked about, who has heard there is a test that can tell me which antidepressants will work for me? Well, maybe not. Okay, I'm a little surprised. Okay, a little bit. So these tests are called pharmacogenomic testing. And what they do is they tell us about the genetic activity of our liver enzymes that break down medication. What they do not do is give us a magic box telling us exactly which antidepressants are going to be the most helpful. So there are a lot of parts in how fast the body metabolizes drugs. And one of those parts is genetic. Another part are non-genetic factors like that can influence that metabolism, like smoking, alcohol use, herbs, St. John's wort's an example of this, and medications. And then another really big one is how much of a medication is absorbed in the stomach, because if it's not actually getting into your bloodstream, it doesn't really matter what your liver's doing. So I will sometimes see people who were told, I can't take this medication. It was on the red list of my genetic testing. That red list, this is GeneSight does this. This is one of the big companies. The red indicates slow metabolizer. It doesn't mean this medication is a no-go forever. What it means is we would be more cautious and start with a lower dose. So it doesn't tell us which medications are the best match for someone's symptoms. So it's important to know how these are useful, but they're limited in their use. And I will also note that these types of tests will often prefer newer and more expensive medications. An example of that is they often really like desvenlafaxine, which is called Pristiq. It's the active form of Effexor. And the reason it likes that is because that's not a medication that needs to be metabolized by the liver. It already starts in active form and it's metabolized, but it starts active and it leaves active. That's why it's saying that. So that's important to know because often people get a list of very costly medications. Jen, the brand, Nature's Way brand, and then I'll put it in here, USP verified is what you're looking for. There we go. All right. So selected medication interactions. There are lots of interactions. These are the ones I think are most helpful for people who don't manage medications to know about. Psilocybin acts on the same receptors as antidepressants. It acts on the serotonin 2A subreceptor. So you may encounter folks who, and maybe you or your loved ones have experienced this, of somebody who's taken an antidepressant for a long time, they try psilocybin and nothing happens. So then maybe they try more. And trying higher and higher doses can increase the risk for serotonin syndrome. But unfortunately, these interactions really aren't well studied because these are medications that are like psilocybin and MDMA are considered Schedule 1, so it's really hard to do research on them. So this is a place where we don't have great scientific information for people here about how to guide safety. MDMA and ketamine are medications that can increase blood pressure. That's an important interaction that you can see there. Cannabis and we'll come back to that one. St. John's wort. Oh, hold on. I want to double check something, so I'm giving you the right information. All right. Cannabis and CBD can increase levels of medication. St. John's wort can increase levels of medication. Cigarettes can decrease levels of medication. So the classic example here is somebody who has an inpatient hospitalization for psychosis. They're doing really well on a medication, but they've been on an inpatient unit where they can't smoke. They immediately leave that hospitalization, they resume smoking, and then their medications stop working. This is a reason why that can happen. Cool. If anybody has questions here, feel free to let me know. And then one
I have a question.
Yeah, please.
So one of my questions is, so you said that cannabis and CBD can increase levels of medication. Does that mean that it could increase the possibility of serotonin syndrome if somebody was taking it alongside an SSRI or SNRI?
Yes, and no. Okay. So theoretically, yes, like the most conservative healthcare information would be, yes, it can increase the risk. And this is that land of mild serotonin syndrome is probably a lot more likely than we know, and severe serotonin syndrome is pretty infrequent. So it is something that I would educate my patients about. This is possible, but not highly likely.
Got it. Thanks.
Yeah. Lots of folks have emotional responses to mental health medication. I'm curious if you all have seen that. I know this is something that I wasn't in my early social work career as good about asking about. One of the things that I didn't ask people about is I wasn't asking my clients with a history of substance use disorder if the experience of taking a pill was triggering for them. And when I started asking, I learned that that's actually not uncommon. Um, so that's something that I ask about now. Sometimes folks actually never started a medication because they looked at that pill bottle and it felt like if I start this, I must be crazy. I must be really sick. Or if I start this, I'll never be able to stop taking this. I imagine that some of you all listening have maybe had this experience yourselves. Certainly, you've seen it with folks you provide care to. These are fantastic places for interventions from therapists. And asking about this can be a really great place to start. Any thoughts, comments here? Cool.
I've just encountered this so much.
Yeah.
And I sort of equate it to like physical chronic illnesses. So the one that I use is just sort of like, like I can function without my glasses. Um, but I function better with my glasses on.
Yeah.
And so this is similar. It's that like it's not that you won't be able to function, it's that like with taking this medication you'll be able to function better. And
Yeah.
that's not the same as dependence.
Absolutely. And this doesn't make you a different person. You're having a hard time now. If you have a less hard time, you might be able to be more yourself. And people sometimes just don't want medications, but felt uncomfortable saying that to their healthcare provider. That's also totally valid. In that case, they don't need to go back. Yeah. Does anybody have thoughts about kind of things you have done in medication realm to be of support for people? I can give some examples that are helpful if folks want to.
Sorry, I was having trouble unmuting. Um, I'm an OT, so I talk to people a lot about consistency with their medications. You know, I took for granted for a long time how hard it is just to take a medication every day. And now that because of some conditions I'm on multiple medications daily, I really get it that it's another thing to keep track of and get into routine. And our clients have really complicated relationships with routine and remembering things and executive function. And so there's just a lot of discussion around very practical things, like how do we actually make taking these medications possible? In addition to all of the emotional components that I'm so glad you just mentioned, and managing the side effects and being aware of, I also talk a lot about being aware of the impacts because they're so slow to arrive often. It's like, well, let's talk about what 6 weeks ago was like. Let's
Yeah.
let's look back and see if let me help you see if there's a change that I can see and I can reflect back if I'm seeing changes because it can be hard to perceive because it's pretty
Yeah.
slow.
That's a great point about helping people notice if there's been a change.
Mhm.
What I tell my patients often is your loved ones might notice before you if this medication is helpful because it kind of turns the dial down in the background. It's not magic beans. You won't wake up overnight and feel like a totally different person because you wouldn't be you if you did. Molly, I'm curious if I can put you on the spot a little bit. Do
Go for
you
it.
have favorite strategies for helping people take medications? Because it's really hard to take a pill every day. Most people prescribed medications don't.
Yeah. I mean, I love Medisets. I always talk about placing your medications or storing them where you take them. So if you are laying in bed at night when you remember to take your meds, that's where your meds need to be. They need to be in arm's reach of where you'll remember taking them. Visual cues, really helpful. Alarms. But it can get very individual with, how people use their space, go about their days. Yeah. But
Thanks.
those are the ones that come to mind. Yeah.
Yeah. Another thing that I'll add here that I think is really helpful is I love treating neurodivergent adults I know that my clients are going to read all about this stuff all over the internet because that's just how their brains work. And we love that. And I have clients who will come back to me and they will have a journal article and they will tell me and they'll be like, I read this and you told me this thing that was wrong. And then we're going to sit together, we're going to look at the journal article and we're going to talk about it. And there's a really good chance I'm going to learn something new. So, what I like to do here is equip people with reliable sources for information about medications. I make sure to talk with people about, I care for this population that are kind of zebras with unusual side effects, but the side effects we're going to focus on and talk about are the ones that occurred in a higher percentage in the clinical trial of somebody who was taking the medication versus taking placebo. So I look to side effects that occur in greater than 5% of people. The ones that occur in 0.2% of people, if they're really dangerous, we'll talk about, but I'm not going to spend a huge amount of time talking about things that are very unlikely. And then, of course, unlikely things happen because of the people that I take care of. And then we talk about it. So what I like to do here are provide good resources to learn about medications and framing of what we're going to worry about, what we're going to have on the back burner because it's very risky but unlikely, and the things that we're not going to spend a ton of time on because they're just very unlikely. So again, I will share the slides so everybody can have the links. NAMI has medication info sheets that are written to be friendly for folks. Medline Plus is a publicly available resource that has lots of information about medications. And then I really like two of the Canadian resources, Choosing Wisely. There's a resource on, sorry for that spelling error, Psychiatry 13 Tests and Treatments to Question. And then another Canadian resource, deprescribing.org, which talks about medication deprescribing. And there's information in there. And then for you all, there are loads of clinical guidelines for psychiatric treatment, which you can read to learn more yourself, knowing that many of you all have my kind of brain and you like all this information. There's just a couple you can look at. The American Psychiatric Association, definitely make sure to check out the year on their guidelines. Some of them are very old. And then questions. For long specialized questions, feel free to reach out to me. I do 2 30-minute spots a month to talk with folks about medication questions. And then in August, I'll be back with a whole presentation about ADHD meds. I'm going to stop sharing in case people have questions.
Can I ask a question about marijuana?
Yeah, absolutely.
So when I am looking for appropriate, well, yes, always appropriate language, but just for clients who have very high anxiety that's impacting their function and who are also fairly heavy daily marijuana users, what do they need to know about marijuana?
So this is talking about cannabis use and mental health is complicated because of our landscape of criminalizing substance use. And so I like towing that line of like, what is evidence-based here, and also making it clear that like, I am a safe place to talk about substance use can be difficult. So I try to think about that framing. And as the THC potency in cannabis has increased exponentially in the last decade, we're seeing different mental health impacts than we used to. So THC is the one that's more associated with psychosis and anxiety, and CBD is more associated with relaxation, maybe some cognitive protection. And what we're seeing are these strains now that have way, way more THC because they're bred to be that way because that's what sells versus CBD. And that's very different than what's naturally occurring in cannabis plants before we were breeding them to be this way. So these very, very high THC strains, what can happen is that over time, people's anxiety can increase and their sleep quality can worsen. And it's more associated with psychosis. But that association with psychosis is more in people who have a family history of psychosis. So they're theoretically at higher risk. So what I talk with folks about is the experience that people will most commonly describe to me with that anxiety and cannabis is that when they ingest their cannabis, they feel better for a period of time. The anxiety feels better. And then it wears off and they often feel a lot worse, more irritable, more difficulty sleeping, more on edge. So that can happen. And then I also educate people about the possibility of cannabis withdrawal, which can look like all of those things too. Cannabis discontinuation. That's the approach that I take. It's not perfect. University of Washington has a case consultation series, and they've been doing a couple of really great presentations about cannabis and mental health lately from cannabis researchers. It's called UW PAC, and those are free. Put that in the chat. Did that answer the question to the best of my ability, Molly?
Yes, thank you. I appreciate that. That was along the lines of what I was thinking, but I wanted a provider's opinion. So thank you.
Morgan, we have a couple questions in the chat. One is it true that SSRIs impact immune system function?
That's a really complicated question. So this is like on the edge of what we don't quite know scientifically yet. What I will say is that depression impacts immune function. That we do know. So I'm kind of curious if you want to add a little bit about like, is there a particular reason you were curious about this? I might be able to answer it a little bit better, but I don't want to speak for something that we don't have clear evidence on yet. So the conversation that I would have with a patient who is telling me like, oh, I'm worried that this antidepressant could impact my immune function is let's also talk about the impact of untreated depression on immune function, because that we do have a lot of knowledge about. Medications are not the only way to treat immune function. So is sleep, so is joyful social connection, so is therapy. So if someone's concerned about that piece of antidepressants, I would kind of zoom out the conversation a little bit. Oh, interesting. Okay. Several clients recently bringing up the concern of why they're getting sick. I honestly, if a client brought this to me, what I would first think about is checking a vitamin D level. Because in the Northwest, many of us are very vitamin D deficient, and that is associated with depression in low levels under 20, and frequent infection. So what I would do if this were a clinical question brought to me is I'd zoom out and I'd look at the best evidence that we have around immune function is a lot to do with lifestyle. And those are things that will also support mental health. So like, are you sleeping? Are we eating nourishing foods and sufficient quantities of them? Are we moving our bodies? Are we doing things that make ourselves happy? And if that's a real concern with them, and I check vitamin D, and if that's a real concern with a medication, and someone is kind of doing all these other things and they still feel like they're getting sick, I see zebras, and so nothing is impossible. And if that's happening, and if they're feeling like, you know, this medication isn't working for me, that would be a reasonable reason to slowly decrease and stop it, or decrease it and see if that changes. How's that for an answer? It's kind of a non-answer answer.
Morgan, could I ask a follow-up question on that?
Yeah.
So conversely, what about like folks who have like autoimmune conditions?
Mhm.
Would, taking antidepressants, possibly increase like flare-ups?
Yeah. This is the realm of the neurodivergent people who have lots of things going on that there aren't great answers. And this is like kind of similar answer. My first thought would be like, let's zoom out. Let's see if we can find something that is more likely that this might be happening. Again, untreated depression, untreated anxiety, that stress load on your body definitely can increase flares. So we zoom out, we talk about that thing. If it really seems like the timeline of starting the medication and the flares are associated with each other, then this would be a reasonable reason to think about decreasing or stopping the medication. So I don't have a great research-based answer for you there, but this is like a listen to the person in front of you and talk about it together, make a plan situation.
Awesome. Figured it was that way. Thank you.
And then I will add there's POTS. There are certain mental health medications that can worsen POTS. That is something we do know. And with MCAS, I have seen folks who respond differently to the inactive ingredients in medications. Sometimes they need all their medications to come from the same manufacturer. So that would be something I'd ask about too.
There's another question in the chat. Can you talk a little bit more about how SSRIs can impact an increase in heat intolerance
Ooh,
slash dehydration?
yeah, great question. So SSRIs are associated with hyponatremia. That means low blood sodium, and that can impact your brain. Usually in people who are not older adults, that's less likely. But neurodivergent adults are very sensitive to all of the things. And we know that there's an overlap with POTS, especially, and hydration for people with POTS is really important. So there's kind of two pieces here. One is that SSRIs can increase the amount that someone sweats, and the other one is that they can decrease blood sodium. Hydration is the combination of how much water is in you and how much sodium is in you, and potassium a little bit, but it's your electrolytes plus your water volume. So that's that part of antidepressants can make your body more vulnerable to dehydration, which especially for somebody with POTS is something we would want to be looking out for and talking about. Did that answer the question?
Yes.
Okay.
So Morgan, oftentimes we will have some time for people to ask questions when we're still recording, and then we will turn it off in case people have more sort of sensitive questions.
Yeah,
So, would it be okay to see if there's any
absolutely.
last questions and then we'll also turn off the recording? Okay, so let's end the recording